First, I'm going to give you some information on ovarian carcinoma facts and statistics. And then we'll talk about risk assessment of the patient and patient stratification by risk. Then we'll go into a little bit more detail on ovarian cancer screening, current methodology, and some recent large randomized and prospective screening studies that have been underway. And then some new technologies and really what's on the frontier for ovarian cancer screening. And then I'm going to round it out with talking about some newer hypotheses about ovarian cancer pathogenesis and how that might impact ovarian cancer screening in the future. So in 2008, these are estimated U.S. cancer deaths, and the males given for comparison. The top 3 cancers in men are prostate, lung, and colon. In women, breast, lung, and colon. And ovarian cancer is relatively farther down on the list. The most common gynecologic cancer is uterine cancer. But if you actually look at U.S. cancer deaths, ovarian cancer moves up the list because it has a relatively high mortality per case. So ovarian cancer becomes the most common gynecologic cancer killer in women in the United States. And the lifetime risk of ovarian cancer in the United States is about 1.8%, which translates to about 1 out of 56 women will get ovarian cancer during their lifetime. The peak age incidence is in the 60s and 70s. If you look at cancer death rates over time in the United States, ovarian and pancreatic cancer have really paralleled each other closely. Uterine cancer here took a rapid fall. This is really uterine and cervical cancer in the 50s when pap smear screening was initiated. Lung cancer rose with the women's lib movement and the onset of smoking in women. But ovarian cancer has really stayed relatively constant over the last 30 or 40 years in death rates. So the ovarian cancers can rise in any of the 3 cell types in the ovary, the germ cell, the stromal cell, or the most common is the epithelial cell. That's really what we're going to focus on today is epithelial carcinomas in the ovary. These cancers have a better prognosis. This accounts for most of the mortality in ovarian cancers. So this basically sums up why ovarian cancer has such a high mortality. Overall, the mortality is about 50%, and that's because most women present with advanced stage disease, the majority with stage 3 or 4 disease at diagnosis, with pretty extensive metastases usually. Few women present with early stage disease where the survival rate is actually quite good. And if you compare breast and ovarian cancer stage for stage for survival, the survival is very similar. It's just the distribution in the stages is quite different. So this is really the major rationale for trying to improve early detection in ovarian cancer, to try to shift people from that late stage into early stage and then improve mortality. But I think there's some question about whether early stage ovarian carcinoma is really the same disease as what we see as advanced stage disease. We know that the survival is better for early stage disease. But the distribution of histology and grade is quite different for what we see now in early stage ovarian cancer compared to late stage ovarian cancer. High grade serous ovarian carcinomas, which is the majority of ovarian carcinomas that present, are actually rare in stage 1, whereas most stage 1 cancers are clear cell, endometrioid, mucinous, and borderline tumors. And the volume of disease that we see in women that present with stage 1 ovarian cancer is not necessarily smaller. And this implies that there may be really less metastatic potential in early stage ovarian cancer, and not that we just really caught it time-wise much earlier. So this is some of the risk factors for ovarian cancer epidemiologically. Not having children is one of the bigger risk factors. Peritoneal talc, though, has not commonly used anymore, is a small risk factor. North American, Northern European descent, higher education or income, white race, early age of menarche, and late menopause. These are very similar risk factors to what we see for breast cancer. And then age, as with most cancers, is a continuous risk factor. There's a number of things that are protective for ovarian cancer. Oral contraceptive use is one of the strongest protective factors, with the longer use and a stronger effect with longer use. More than 10 years of use with a greater than 50% reduction in risk. Bilateral tubal ligation also has about a 50% reduction in risk of ovarian cancer. Hysterectomy, not quite as effective as tubal ligation, but also reduces risk of ovarian cancer, and that's hysterectomy without oophorectomy. And then each pregnancy, each full-term pregnancy is about a 10 to 15% reduction in risk for the woman. This is different than for breast cancer, where it's the age of first pregnancy that matters the most. For ovarian cancer, it's really just the number of pregnancies that add up to reducing risk. But really, one of the strongest risk factors for ovarian cancer is family history. One first degree relative with ovarian cancer confers about a 2 to 3-fold risk. 2 relatives with ovarian cancer about a 3 to 5-fold risk. And actually being identified with a BRCA1 or BRCA2 mutation is about a 10 to 30-fold increased risk. Having a personal history of breast cancer and one first-degree relative with breast cancer is about equivalent to having one first-degree relative with ovarian cancer. So I'm going to talk about that in a little bit more detail. For most cancers, we think that there's a proportion of cancers that are what we call inherited and a proportion of cancers that are familial. And what we mean by familial cancer is when people share either low penetrant genes or shared exposures create clustering within families. But when we talk about inherited cancers, we're talking about highly penetrant cancer susceptibility genes that are usually transmitted in an autosomal dominant fashion. So this is just really for comparison. Breast and colon cancer are relatively typical, where about a quarter or a fifth of cancers are you see familial clustering, and a small portion, about 5%, that are really inherited. And ovarian cancer of all solid tumors has the highest proportion of inherited cancers, such that probably about 15% of people with ovarian carcinoma have a highly penetrant cancer susceptibility gene. So there's really 2 hereditary ovarian cancer syndromes. The first is hereditary breast and ovarian cancer, and that is associated with mutations in BRCA1 or BRCA2. BRCA1 and BRCA2 mutations confer susceptibility to breast, ovarian, fallopian tube, and peritoneal cancer. The lifetime risk of breast cancer is approximately 60 to 85%, so very high. The lifetime risk of ovarian cancer is about 20% for women with BRCA2 mutations and about 40% for BRCA1. There's also increased risk of early onset prostate cancer, pancreatic cancer, and male breast cancer in these families. So this is a typical pedigree. This was a patient that presented to me. She had stage 4 ovarian cancer. She had previously been diagnosed with breast cancer at age 42. Her mother had had both breast and ovarian cancer, as had 3 women in the previous generation. So this is clearly an autosomal dominant transmission pattern. She was identified with the BRCA1 mutation. And then that I consider a fully preventable cancer. Hereditary ovarian cancer syndromes also includes Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. This syndrome confers an increased risk of colon cancer, endometrial cancer, stomach cancer, ovarian and urinary tract cancer. The lifetime risk of endometrial cancer is 40 to 50%. The lifetime risk of ovarian cancer is about 8 to 10%. And the lifetime risk of colon cancer is somewhere between 50 and 80%. And it's actually thought that women with Lynch syndrome have a higher risk of endometrial cancer than colon cancer, and men seem to have a bit higher risk of colon cancer than women do. But often these women are followed by gastroenterologists in the community, and the gynecologic cancer risk is not always adequately addressed. So this would be a pedigree of a typical Lynch family, where there's a combination of colon cancers and some of the other Lynch cancers in the same family. And often you can see more than one cancer in an individual. There's, again, an autosomal dominant pattern. You tend to see less skipping of generations because both men and women get the cancer, whereas with hereditary breast and ovarian cancer, if the transmission is through a male member, you may not see cancer in that individual. So it's thought that between 1 out of 300 or 1 out of 800 non-Jewish white women will carry a mutation. Because these are 2 large genes, full sequencing hasn't been done in thousands of people to actually really know what that rate is. Founder mutations occur in many populations, such as in Iceland, there's a common mutation in the BRCA2 gene. And there's 3 mutations that are common in the Ashkenazi Jewish population, 2 in BRCA1 and 1 in BRCA2. And the 3 founder mutations together in the Ashkenazi population occur in about 2.1% of people. Because that rate is so high in this population, 30 to 40% of ovarian cancers that occur in Ashkenazi women will be associated with either a BRCA1 or BRCA2 mutation. So, and also about 10 to 12% of breast cancer. So even if there's no family history, if you're Ashkenazi and you have ovarian cancer, there's a pretty good chance that you have an inherited cancer and should be offered genetic testing. When BRCA1 and BRCA2 were first identified in the mid-90s, it was considered to be quite controversial whether women should be offered genetic testing on a clinical basis. Many people argued that this should only be done in the context of research because it wasn't clear whether or not we would be able to reduce morbidity or mortality. So if we can't do anything about it, then why test them? And a lot of information has accumulated in the last 10 years, and such that in 2005, the U.S. Preventative Health Task Force Service actually came out with recommendations that women who met certain criteria should be offered genetic counseling and the option of genetic testing. And this mostly came about because of evidence for breast MRI, for bilateral mastectomy, and for oophorectomy as being highly effective. So they recommended that women with family histories suspicious for mutations be referred, and what the criteria that they used were 2 relatives with breast cancer if one was less than 50, 3 first or second degree relatives with breast cancer at any age, breast and ovarian cancer in 2 first or second degree relatives, a first degree relative with bilateral breast cancer, a first or second degree relative with both breast and ovarian cancer, or Ashkenazi ancestry, and a first degree relative with either breast or ovarian cancer or male breast cancer in the family. And I think what's important to think about with that list is this is for a woman who's coming in who's not herself affected by cancer. And that would actually identify 2% of the US population would have a family history that meets that criteria. That's by their own estimates. So at this point, while genetic testing is becoming increasingly common, we have just barely scratched the surface of the iceberg of women who should be considered eligible for genetic testing. So when we think about genetic testing, we want to begin with an affected individual. So going back to this patient of mine, you might say that in what way is genetic testing going to help this individual? She already has stage 4 ovarian cancer and she has breast cancer, but the way that we can help her is to identify risk, find out why she got cancer, and identify whether or not her daughter has inherited that risk. And if the daughter is the one that presents to you wanting that information, it's much better to go and test her mom first. And that's because if the daughter gets tested and she's negative, we don't know if she didn't inherit the family mutation or if we just can't identify the mutation in the family. Whereas once we identify the family and the family mutation, we can give that daughter a definitive answer whether or not she has inherited the risk. So BRCA1 and BRCA2 testing in the United States is done through a company called Myriad Genetics. They have a patent, and their standard test is DNA sequencing of both genes and then a panel of 5 gene rearrangements in BRCA1. The cost of that test is just over $3,000. So deleterious mutations are usually frameshift mutations, and they cause protein truncation. But sequencing does miss large deletions, duplications, and insertions in the genes, which are thought to be about 10 to 15% of mutations. If a mutation is known in the family, then you can just usually test other family members for just that family mutation, and the cost is a lot less. So in August of 2006, Myriad Genetics started providing an option to test for gene rearrangements more than just the rearrangement panel that they had offered. That's a $650 test. Insurance may not pay for it. And they've actually supplied no data for sensitivity or specificity of this test compared to other more established technologies that are used for identifying rearrangements around the world, which we don't have access to because Myriad has a patent, so we have to use their technology. But it does seem to be identifying about 10% of mutations, which is what we would hope that it would identify, so it does seem to increase the sensitivity of the current testing. So really, genetic counseling now needs to include a discussion of BART testing and cost. Because a patient's not very happy when they come in for genetic testing if you go through this whole testing process and when it comes back you say, well, that's great, I'm glad it's negative, but it wasn't really like a very good test and now we need to do something else, but your insurance isn't going to pay for it, then they get pretty irritated. So we try to disclose all that up front. If patients were tested before August of 2006, I think it's reasonable now to offer them the BART testing as a complement to their previous sequencing that was done. So what does a negative analysis mean for BRCA1 and BRCA2? It usually means that the patient doesn't have an elevated cancer risk, but not necessarily, because you could have missed a mutation with testing, or they may have a mutation in a different cancer predisposition gene that still increases the risk. So the only truly negative test is one in which a mutation has been identified in the family already. But comprehensive negative testing, including comprehensive rearrangement testing, is pretty reassuring in an unaffected individual or in a family that doesn't have ovarian cancer. But testing results have to be interpreted in the context of the individual history and their family history as well. So I really only kind of gave that background to sort of segue into the ovarian cancer screening, which is supposed to be my topic today. For patients who actually have mutations, we generally begin screening at the age of 25 to 30. The NCCN has just recently come out with newer guidelines saying to initiate screening at age 35. But really, I think beyond age 30, we want to think about doing screening at least twice per year because interval cancers have been identified in these high-risk women when annual screening's been done. And then we're going to talk about the evidence for the efficacy of ovarian cancer screening, but really that's relatively limited. So for these really high-risk women, we actually recommend that they have risk-reducing salpingo oophorectomy, which means removing their ovaries and fallopian tubes, around age 35 to 40. So what do we want from an ovarian cancer screening test? We want really high specificity, and that's critical because positive tests are going to lead to surgical intervention. So this is different than, say, for breast cancer. If you have something on the mammogram that's suspicious, then people put a needle in, they get some cells. It's invasive, but it's not as invasive as what we do. We never just put a needle into an ovarian mass because we risk potentially spreading cancer in the peritoneal cavity. So we usually remove, when we need a pathologic diagnosis, we remove it as intact as possible, either through surgery or through laparoscopy. So high false positive rates are really not acceptable to either women or their clinicians. And because of the relative rarity of ovarian cancer, it reduces the positive predictive value at any given specificity. So even a test with 98% specificity, which sounds pretty good in a paper, would result in 50 surgeries for each cancer that was detected. And it's estimated that the required specificity to yield a positive predictive value of 10% is 99.6% for ovarian cancer, and that's for the postmenopausal patient, where the risk is higher than the premenopausal patient. So the first strategy that we use for screening is ovarian ultrasound. And it's relatively nonspecific and it's pretty expensive. The transvaginal approach has been shown to have greater resolution, basically because what you can see here is that the probe is actually closer to the ovary than when you do a transabdominal ultrasound where you're looking through the bladder this way. Color flow Doppler imaging has enhanced the sensitivity somewhat of transvaginal ultrasound because cancer has been shown to have decreased vascular resistance. So that's also been applied. And this is just how a typical ovary looks under ultrasound. Morphological indices and scoring systems have been established to try to standardize how you interpret an ultrasound, particularly this has been necessary in large clinical trials. So the other approach we use is measurement of CA-125, which is a protein in the blood, was recognized in 1981, and it's really the gold standard for ovarian cancer biomarker. It gets a lot of criticism, but it's actually, to date, like no other biomarker has compared well to it. It's encoded by the gene MUC16, which was identified as encoding CA-125 in 2001. It's elevated in approximately 50% of stage 1 ovarian cancer, so it lacks quite a bit of sensitivity for screening. But it is a sensitive marker for following response to treatment, and we use it a lot in that context. And identifying recurrence with CA-125 often precedes radiologic diagnosis of recurrence by many months. But false positives are common, and particularly in the premenopausal age group. Many things can raise the CA-125. Basically, any inflammation in the abdominal cavity can raise CA-125. So that includes endometriosis, fibroids, pelvic inflammatory disease, pancreatitis, diverticulitis, and even pregnancy, particularly the first trimester and postpartum, can raise the CA-125. So what are some pitfalls that we need to think about as I start to talk about ovarian cancer screening studies? One thing is that mortality is really the gold standard for evaluation of any screening. And that we don't really have any studies that have mortality data for ovarian cancer. So stage shift is used as a substitute for improvement in mortality. If we see a lot of early stage ovarian cancer diagnosed, then that is somewhat promising. But the way the studies are often reported is many early stage cancers are often granulosa cell tumors and borderline tumors. And these are tumors that are typically present in stage 1. So they may not actually represent a stage shift. They may just represent sort of incident cancers that wouldn't have otherwise been troublesome that were identified because people had a routine ultrasound. That's not me. Few cancers have been identified even in pretty large studies because of the low prevalence. And then recent studies are really limited to the postmenopausal age group, and they may not be applicable to younger women. And few studies really have significant numbers of women with known genetic risk to adequately evaluate the highest risk women and how screening works in that population. So this is just a summary of some of the largest screening studies that have been done to date in the general population. This first study is a Japanese study that used just transvaginal ultrasound, screened a very large number of women. They found 22 cancers, 17 were stage 1, which is promising. But I think it's important to note here that only one of these, this study is the only one of the studies that actually surgically staged patients. And about a third of people with clinically staged stage 1 ovarian cancer will be upstaged if they have the full surgical staging, which includes looking at lymph nodes and for microscopic spread. So probably this estimate is a bit of an overestimate in terms of stage 1, but it's still relatively promising. What's a little bit more discouraging here, and as you look down this list, is the number of surgeries that are done for each cancer is pretty high. And the one study that has a lower number of surgeries done per cancer, a higher positive predictive value, was a combination of transvaginal ultrasound and CA-125, where CA-125 was an initial screen and transvaginal ultrasound was done subsequently. And that is a group from the United Kingdom that has gone on to really make some progress in ovarian cancer screening that we'll talk about. So in total, more studies have been done than just this, but these were for the largest studies. Over 100,000 women screened, only 47 cancers identified. So screening a large number of women for multiple years still to identify a few cancers. It is promising that the stage 1 population of those cancers is more than 50%. And this is excluding borderline tumors and granulosa cell tumors. But still, again, a high number of surgeries per cancer. So the U.S., there's two large randomized controlled prospective trials of ovarian cancer screening. In the United States, it was part of the PLCO trial, which was the prostate, lung, and colon and ovarian cancer screening trial. This was a prospective randomized controlled trial using annual transvaginal ultrasound and CA-125. Recruitment was between 1993 and 2001 in 10 centers around the United States. And the preliminary results were relatively recently reported. And they demonstrated that 28,460 women were randomized to screening that had one or more ovaries. And 43 invasive cancers were identified in the ovary. 43 total, 9 in the fallopian tube or the peritoneum and 34 in the ovary. 13 borderline tumors, so pretty large number of borderline tumors, which are of questionable significance. But if you exclude the baseline evaluation, because then you're going to find a lot of incident cancers that are in the population, they identified 26 invasive ovarian cancers and 6 fallopian tube or peritoneal cancers, and a fewer number of borderline tumors. The positive predictive value is only 0.6% in what they called normal risk patients and 1.6% in what they called a high-risk group, which wasn't exactly anywhere near the risk of a mutation carrier. You really only had to have one relative with breast cancer less than 50 to be in that high-risk group. So I think what's most concerning about this is that 5% of screens resulted in a positive screen, and 21% of those positive screens ended up leading to surgery. So that if you calculated it out, more than 1,000 surgeries were done, which actually translates to about 26 surgeries for each cancer identified. But they have not yet released all the results of the trial, and so as the endpoint of the trial is mortality, so that's going to go on for another few years. So this no stage information or case characteristics have yet been released. So we don't have information about whether there was a significant stage shift in this study. The spore here at the UW and the Fred Hutch, the ovarian spore, was relatively instrumental in coming up with a new way to look at CA-125 using a statistical approach that relies on patients having had multiple measurements of CA-125 over time. And the normal is then set for that individual against their history as opposed to against the population norm. So for instance, our lab lists CA-125 as normal being less than 30 or equal to 35. But for an individual patient, they may range over time between, say, 10 and 15. And so when their CA-125 goes up to 22 or 24, that may be a rise. But against the lab norm value, it would appear to be normal. So that's what has been looked at to increase the sensitivity. And the British group took this approach and created what they call the risk of cancer algorithm. And that's basically using this statistical model and combining it with some other risk factors to predict what the patient's risk is based on their CA-125. And basically their age are the two main things that go into the risk of cancer algorithm. And this they applied retrospectively to one of their large screening studies and showed that there was a significant improvement in sensitivity and specificity and an improvement in the positive predictive value. So they then did a prospective pilot study of ROCA, or the risk of cancer algorithm, which was reported in 2005. And that involved over 6,000 women using this combination of CA-125 and the algorithm. And then if people had a positive or intermediate first level, they then went on to transvaginal ultrasound. And the positive predictive value was 19%, which is quite a bit better than any other screening study has really shown to date, with a specificity of 99.8%. So they used this to put this into one arm of a very large United Kingdom trial of ovarian cancer screening, which they abbreviate this way. And this is a prospective randomized controlled trial that has recruited 200,000 postmenopausal women aged 50 to 74. And the primary endpoint that this study is powered for is ovarian cancer mortality. There's basically three arms, one with no screening, 100,000 people in that arm, one with transvaginal ultrasound only with 50,000, and one with the CA-125 ROCA algorithm, where the positive screens then get a transvaginal ultrasound. And they have an 80% power to detect a 30% reduction in mortality. And also includes cost effectiveness and compliance analyses, and it's due to be reported in 2012. So this is probably the most promising study that we have right now for whether or not ovarian cancer screening is going to be applicable to the general population. So you can see that these are really large, very expensive kind of studies to do. And so you can't just take any marker that you have and throw it into a screening study to prove efficacy. So how do we evaluate new candidate biomarkers for screening then? So the first step usually is to evaluate the marker in a series of blood samples from women with cancer and benign disease, including stage 1 cancers that people have already accumulated. But this clearly doesn't translate to early detection in the prospective settings. And no marker to date has proven prospectively to be superior to CA-125. And really the current goal is not to replace CA-125, which I think was the goal 10 or 15 years ago, but to find markers that complement CA-125 so that we can hopefully improve the sensitivity and the specificity of CA-125. And so there's a number of biomarkers that have been identified in the last 5 years or so that have been picked up by companies developing tests. And the commercial clinical trials are generally now focused on differentiating benign from malignant pelvic masses, which is not the same as screening asymptomatic women. But this is really a much more cost-effective approach to showing some utility for your test. And I don't think any of these companies are really very interested in funding a large screening trial themselves. So one of the most promising markers is HE4, and that was first identified by researchers at the UW and the Hutch here, Ingegard Hellstrom and colleagues. And that has been translated into a commercial test by Fuji Ribio and was released in Europe in March of 2008. And it's to be used in conjunction with CA-125 for women with pelvic masses. And it should be available sometime this year in the United States. So I think that you'll see that being used. It's been tested for women with pelvic masses, but I think once the test is out there, people are going to end up using it for screening, whether there's data around or not. So there's a lot of other markers that are kind of in that sort of development phase. And mesothelin is probably one of the most promising ones, was also identified at the Hutch, and osteopontin, kallikrein 11, and there's a number of others. And another way of that researchers are looking at these markers without having to do huge screening studies is to look at serum samples that have been gathered as part of large studies like either the PLCO data trial or the Women's Health Initiative trial, where the trials were so large that during the course of the trial, a number of women did get ovarian cancer. And then because blood samples were obtained during the course of the trial, there's a number of blood samples that they have prior to a clinical diagnosis of cancer. And so then that becomes a very cost-effective way to look at, can a marker be elevated and at what time frame before a clinical diagnosis of cancer was made. But those are very precious samples because the number of cancers are still small in those studies. And so you have to jump through a lot of hoops with your marker to get sort of into that queue. But I think that's something that is going to be getting reported in the next couple of years. So there was a big sort of, I call it the proteomics fiasco in ovarian cancer screening. I think it really kind of set back proteomics as a mode of screening for other cancers as well. This was an NCI intramural study that looked at pattern recognition with basically low-resolution mass spectroscopy. It was reported in 2002 in The Lancet, and it was a retrospective serum analysis using an initial test set of 50 cancers and 50 controls. And so they're looking at thousands of peaks in control cases and thousands of peaks in cancer cases, and just not caring what the peaks are, but looking for a pattern recognition that differentiates one from the other. And they said that they then, once they had the pattern, then tested this pattern on a validation set of 50 different cancers and 67 controls. And they said that they had 100% sensitivity and 95% specificity. So that came out with a lot of hoopla. People got really excited. But again, this is a retrospective study. It was not a prospective screening study. It was a collaborative study with a biotech company that had developed the pattern recognition system. And this company is called Corologic Systems, and came out with a test that they called OvaCheck, which was going to basically become available for ovarian cancer detection, supposedly. And they plan to release this pretty quickly after this study came out in 2003, and they were going to release it under what's kind of called the homebrew rule, which means that no FDA approval is needed for laboratory tests that are done in the home lab, and that's different than tests that are packaged and sent out that people can do in their own laboratory. And it's regulated by CLIA instead of the FDA. But there was really a huge outcry in the research community about that this was a premature release of the test, that it hadn't been tested in screening, that nobody really knew what any of these peaks were. And a lot of researchers in proteomics, there was a bunch of papers that reanalyzed the data and said that the differences were in the noise area of spectroscopy. And so there was a lot of controversy about this. And so the FDA then decided to put a hold on this test and actually came out with new regulations regarding marketing of multi-light assays, which I think has impacted how these tests will be offered. So 5 years later, if you go to their website, there's no timeline for when this test will be released. And a number of people have sent the NCI researchers blinded samples from their ovarian cancer banks, and this data is really yet to be reproduced. So what are some of the obstacles to improving screening? Some of them we've already mentioned. One is the low prevalence. Another is the invasive procedures that are required when you have positive screening. And then I think a huge problem for ovarian cancer is that there's no identifiable precursor lesion that can be targeted for screening or for prevention. And so this is different than some of the cancers that have been most successfully targeted for screening, such as colon cancer, where there's precancerous polyps are easy to identify, such as cervical cancer, where precancerous lesions are also identifiable. So what about high-risk women also? These studies that I've been talking about mostly geared towards people at low risk. And so most of these big screening studies have been done in postmenopausal women, and they may not be applicable, but randomized controlled trials for high-risk women are really not feasible. They're not ethical, and they're not feasible. And genetic testing is increasingly clarifying risk for women. So that risk-reducing salpingio-oophorectomy, the prophylactic surgery, which we call RRSO, has become standard of care now and has become an NCCN guideline to offer it to mutation carriers and preferably they should do it by the age of 40 if they've completed childbearing. So recent trials for high-risk women have had few cancer endpoints because the highest risk women are getting genetic testing than having their ovaries removed. The more intermediate risk women are not at such high risk, so they're not getting cancer. And so even the screening trials that have been attempting to gear for the really high-risk women have been limited. It's good for the women, they're not getting cancer, but it pretty much obviates the possibility of doing screening in this population. So I'm going to talk a little bit about risk-reducing salpingio-oophorectomy as prevention. Studies show that there's about an 85 to 96% prevention in women with BRCA1 and BRCA2 mutations. It's not 100% because there's still some residual risk of primary peritoneal cancer in these women. But it has an additional benefit when done premenopausally of reducing breast cancer quite significantly, 50 to 60%. And for women who have maybe up to an 80% lifetime risk of breast cancer, that's a very significant risk reduction. But the downside, of course, is surgical menopause with both quality of life impact and also other long-term health issues that go along with that. So this is one of our families who, this young woman, she's actually a physician, was identified with breast cancer at age 34. She was found to have this BRCA2 mutation, and she had presumed that this came down from her dad's side of the family because there was a couple breast cancers here and he'd had prostate cancer. But when he was tested, he was actually identified to be wild type. So there's essentially two explanations for this. One is she got the mutation from her mother, or this is not her father. So maybe unfortunately or fortunately, I'm not sure which, her mother did have the mutation. And so here's a 65-year-old woman who is herself unaffected. And she had never realized that she herself was at high risk for breast and ovarian cancer. So she underwent, because of this information that she got, and it turned out that when we followed this out over time that this actually was transmitted from her father. So there had been very little cancer history in her family. So she underwent risk-reducing salpingio-oophorectomy. So at the time of surgery, she was identified with a carcinoma in situ, and basically this is a neoplastic lesion in the fallopian tube, high grade, but not invasive through the basal lamina. So this was not an isolated case over the last 10 years as we've sort of changed our pathology practice and started really closely sectioning ovaries and fallopian tubes in these high-risk women. We've identified a number of cancers or what we think are precancers. And I think what's important to notice is a few things. One is all these women have basically BRCA1 or BRCA2 mutations. Their age is a little bit older than when it's recommended that they undergo surgery. That just may be when they found the information, not because they were putting it off. And if you actually look here at where they were identified, and quite a lot of them are identified in the fallopian tube. So again, a lot of them in the fallopian tube, a little bit later age of onset, and basically all mutation carriers. So this is another sort of typical one. This is on the left is a view of a normal fallopian tube. Here is the normal pattern with the thin layer of epithelium surrounding the tufts. And here is a fallopian tube carcinoma in situ right here. And here it is under higher power. And what's notable for this woman who has a BRCA1 mutation is that, which is typical of what we see, is that this is it's a serous histology. It's very high grade. So even though this is a non-invasive lesion, it looks very much like what we see the ovarian cancers that later develop in these women. And P53 staining is also pretty typical of these lesions. And that's her pattern with abnormal P53 expression. So what are the predictors of finding these neoplastic lesions in these women? One is that they have a mutation. The rate was about 12% in mutation carriers over the last 10 years. Older age is a significant predictor. And then it's been shown, we've shown that if you have a careful pathologic protocol and do very close serial sectioning, you're more likely to find these small lesions than when you don't have such a protocol. And registry studies typically have about a 2% occult cancer rate for women undergoing a risk-reducing subphalangeal oophorectomy. And the vast majority of these cancers have actually occurred in the fallopian tube. So that makes us think a little bit about what is the origin for ovarian cancer, at least in mutation carriers, if not in women with sporadic cancer. There's only been one high-grade in situ lesion of the ovary that's been reported in a woman with a BRCA1 mutation. But dozens of these high-grade lesions have been identified in the fallopian tubes of women with mutations. So another point to think about is that women with oophorectomy who did not have their fallopian tubes removed before that was realized to be such an important part of the surgery have a higher rate of what's later called primary peritoneal cancer. So that has led us to what we call the Tubal hypothesis. And what we hypothesize is that many hereditary ovarian and peritoneal carcinomas are actually seeded from neoplastic cells that arise in the tubal epithelium. And my research is kind of really looking into that closely in a couple different ways. One is we're characterizing the histology and the protein expression of BRCA1 and BRCA2 tubal epithelium. And we're identifying premalignant gene expression patterns in the tubal epithelium of mutation carriers. And we hope to have some really promising data out on that pretty soon. And we're just starting to explore minimally invasive approaches to accessing the fallopian tubes for screening and for obtaining biologic specimens to follow that out.
It was around 10 years ago that mentioned ovarian tumors in women who had oophorectomies. You sort of alluded to that. Do you have any comments on that?
Yes, so that's when the ovaries are out and it looks like ovarian cancer, we basically, by default, it's called primary peritoneal cancer because it's presumed that if there's no ovaries, we can't call it ovarian cancer. But it typically has the same histologic pattern, and men don't get it. So, there's something different about women that lead to those serous carcinomas of the peritoneum. So some of those may be seeded from the fallopian tubes in women because if somebody doesn't have ovaries, we just call it peritoneal cancer. But if somebody does have ovaries, there's basically a definition that if there's less than 5 millimeters of invasion in the ovarian stroma, we call it peritoneal cancer. And if there's more than that, we call it ovarian cancer. But the bulk of disease may be outside the ovary. And it's just called ovarian cancer by definition, pathologically. And we don't really know where any of those cancers arise, whether they arise in the peritoneum, the ovary, or the fallopian tube.
Thank you for a very nice talk. A couple questions about CA125. Outside of a clinical trial, do you think there is reason in clinical practice currently for women who have first and second degree relatives with ovarian cancer, for those women to be followed?
Yeah, so, it's a great question. What about the women who's sort of at an intermediate risk? And I think the most important thing, since there's not a lot of familial clustering in ovarian cancer, I think we have the luxury to say that the reason that people are at intermediate risk because they have one first-degree relative is because they have a certain chance of having a BRCA1 or BRCA2 mutation. So they're either actually at much higher risk or they're probably at population risk. So I think the first thing for somebody who appears to be at intermediate risk of ovarian cancer based on their family history is to do a really careful pedigree and to basically refer them for genetic counseling and consideration of genetic testing so we can separate out the high risk from the low risk women. And I think it's a bit of a mistake to take people that we think are truly intermediate risk because we don't have any way to say that they're high risk or low risk and just offer them screening, because then we're basically offering them something with no proven efficacy without at least discussing the options. So while oophorectomy is more invasive and has obviously major impact hormonally, et cetera, on the patient, it is effective. And so I think if you're going to offer somebody something without known efficacy, we also have to at least discuss the alternative. And so I think it's actually the person who's in the gray zone, the intermediate risk, that's a lot harder to manage. But I do think that CA125, may be useful when we start to use this algorithm. And I think that it's likely that that's really going to become a mainstay. And in fact, at least one of the labs in Seattle is looking at their CA125s that way and reporting them out that way. So I think that that is an algorithm that it could be applicable to clinical labs in general. If you have multiple results on the same patient, they could be reported out differently than on a population norm.
I recently heard of a patient that didn't want to disclose their genetic risk to other family members, and I'm wondering if there's an ethical or a policy direction that these things are heading.
Well, I think there's definitely ethical issues with that, and there's been some trial law related to whether or not there's a obligation to disclose results, and basically it's basically come out more on the privacy end than the obligation to disclose end. So physicians are really not at risk if they don't inform other members, and in fact they really can't inform other family members without that patient's permission. So that's basically where it's ended up now. I think that is an ongoing issue that I think we're trying to work out as more and more genetic testing is done. Sometimes I think another issue that comes up in family dynamics is that if one sister is really against the concept of genetic testing and one sister has it, then she tests positive and she has her ovaries out, or she has a bilateral mastectomy or what have you, then it's pretty obvious what the test results are. And so even for somebody who chooses not to have testing, you can't necessarily maintain total privacy for that family member.
Another question?
Oh.
Do you want to comment about public health and economic consequences of 2% of the population being screened for testing that might cost $2,000 to $2,500?
Yeah, well, so that could go in a lot of directions. I was giving a talk on Friday about genetic testing for primary care physicians, and the rep from Myriad Genetics was there. I'm not sure he enjoyed everything I said, but I think one thing is we shouldn't be allowed to patent genes. They used a lot of public data to be the ones that got the final sequence, and that patent has been thrown out, and the European Union isn't basically respected anywhere else in the world, though it was an international patent they applied for. So that, I think, is one thing that keeps the cost that high. If you look at genetic testing for other cancer susceptibility genes, it's not as high as it is for BRCA1 and BRCA2. There's no competition. We're not allowed to use new technology, so I think that's one issue. They say that they want to get sequencing of the human genome down to $1,000 per person. And they say that's not that far away. So I keep wondering how that's possible if sequencing 2 genes costs $3,000, that we're going to be able to sequence the whole genome for $1,000. Genetic testing is expensive right now, and it will have to become more affordable for it to be used in clinical medicine broadly. But right now we're excluding a lot of people from that information. A lot of Medicaid does not pay for genetic testing. Medicare only pays for genetic testing on Plan B if you have cancer already, which is sort of a little bit beside the point. So yeah, there's a lot of issues. And then even if it's financially accessible, socially, we don't do a very good job getting that information out to diverse socioeconomic groups either. So there's a lot of work that needs to be done to translate this information clinically, I think.
And 2 related questions. One is, how good a model is BRCA1 mutation associated ovarian cancer for sporadic ovarian cancer? And then sort of follow-up question is, you've been collecting blood or serum from the BRCA1 patients before or at the time of their oophorectomy or second oophorectomy, because those could potentially be useful materials for testing various sort of screening.
Yeah, so I want you on the NIH review panel that looks at my grant. So I think that BRCA1 and BRCA2 model ovarian cancer is likely to be a good model for sporadic cancer because if you look at the protein or the message level for BRCA1 and BRCA2, the majority of ovarian cancers have reduced expression of those. Histologically, the typical cancer is typically high-grade in serous or undifferentiated carcinoma in either type. And they both have high rates of p53 mutations, so there's a lot of overlapping similarities. In terms of whether or not the Tubal hypothesis will apply to sporadic cancers, I think we just don't know that yet, but I think that as a model for the molecular pathogenesis of ovarian cancer, we hope that it's good. We hope to be able to work on more than just the 10 to 15% of ovarian cancer that arise in mutation carriers. And then secondly, basically all these women that undergo risk-reducing surgery at the University of Washington, I've not had yet one refuse to be in our research that involves tissue banking of samples. Most of the carcinoma in situ samples, et cetera, are identified in fact, all of them have been identified in the final pathology in paraffin blocks, where we can't do the same kind of things that we can do in the frozen tissues, but we still access those tissues as part of our research. So these women are highly motivated to participate in research because they're concerned about their own daughters and the risk to them, so that they participate in a whole variety of studies, including the tissue studies.
My question was whether you collect blood or serum on it.
Oh we collect everything we can on them. We collect peritoneal fluid if they have it, washings if they don't, urine, plasma, and then ovarian and tubal tissue.
I think we should, I'd imagine that if those patients with, these sort of early lesions would be good, I guess their blood would be useful.
For looking at biomarkers. Yes. So that list I showed you, there's only about 12 patients that have those really, really early lesions. They've all had normal CA125s, and even normal based on their own normal, like 8 or 10 or whatever. And so what we need is for people to show that they have a really sensitive marker, and then I think that those samples will be one of the earliest ones that we can look at in terms of paired blood samples.